Well, spine of a child is not a miniature adult. It has unique anatomy and function. It has growth potential, and that is why it needs special consideration. The vertebral body develops with 3 centers. They all meet here. It models and maintains the integrity of spinal column. Younger the child, smaller the size of spine. Intervertebral disc and annulus is more expansile in children than in adult. Well, there are certain growth issues in an immature spine. Each vertebral ring apophysis grows by 4.5 mm per year for axial column growth. Thus, each vertebrae contributes about 1 millimeter per year. And it's likely to be more in accelerated growth phase, that is first 2 years of life, and pre-pubertal. Now, there are certain growth consideration of immature spine. We do know that growth rate of spine varies according to age. In utero, the spine grows at extremely accelerated rate. From birth to 2 years, it develops at an increased rate. From 2 to 10 years at a steady rate. And finally, during the pre-pubescent growth phase, it grows at increased rate again. Now, there is a direct relationship between growth of spine and development of spinal deformity. And that can be appreciated well, that if there are 2 facts, that if the apophysis is loaded, then it retards the growth. If apophysis is not loaded, it accelerates the growth. And that's the reason why in quadruped we have a taller vertebrae, while in human beings, which loads the vertebral apophysis, we have a less height of the vertebral body. Now, if patient has some spinal deformity, and if vertebral column is eccentrically loaded, some part of apophysis is loaded in a different rate than the other different load than the other part of the apophysis in the same vertebrae, then some part of the vertebrae will grow faster, some part of the vertebrae grow lesser. And that is the basis why the spinal deformities, any type of spinal deformities, they grow in children. TB spine in children, well, how common it is? Yes, it's very common because it is in the younger age group, a good number of patients, and it is reported as early as 4 months in a child of 4 months. How does the TB spine in children is different than that of adult? Because destruction is more in children than in adult because they are cartilaginous. Early and severe deformity occur. Deformity progresses with growth, and surgery affect the growth potential. And these 4 features make the TB spine in children different than in the adult. If you look at this, that this is a reconstructed CT in a, and you see that in a disease segment, there's hardly any shadow of a bone. You could see here 3D reconstruction, there's hardly any bone. See the axial images, there are hardly any flakes of bone. This cartilaginous vertebral body in a younger child has just melts away. That is why destruction is more severe. That is why deformity occurs early and it is more severe. Now, this deformity progresses with growth, as seen in this example. In 2 years' time, this deformity has progressed. Surgery also affects the growth potential, as been studied in this series, where anterior resection of bone and fusion was done in one group. Another group, only posterior fusion was done. In another group, combined anterior and posterior fusion was done. And in last, anterior debridement without fusion was done. And the results was that anterior fusion alone gave the worst result because anterior growth potential has been obliterated. Combined fusion and anterior debridement give equal growth. Anterior debridement without fusion best in term of kyphosis. So overall, radical anterior resection of bone destroys the anterior growth potential and limits the capacity for spinal remodeling. And that is why, as far as possible, lesions should be debrided, not the excised. And 2 posterior elements do contribute to some growth. Now, coming to management principle and diagnosis. Well, diagnosis is always clinical, radiological, imaging, hematological, bacteriological, and histological. They are the same as for the adult. But I would just like to put one issue here, that this child reported 2 months ago to us. It is about 4-year-old child with such a severe grotesque spinal deformity. And one could see here, if you see that all scalloping of vertebral body, number of vertebral body destroyed, and this part is hardly all body has been destroyed. Now, when we saw the record of the patient carefully, He was carrying one X-ray which was here. One could see here the diagnosis was written on this X-rays. There is such a severe shifting of tracheal shadow and such a severe destruction, but deformity is not severe. So probably this child should have been diagnosed and treated at this stage before such a severe deformity would have occurred. Well, treatment principle, drug therapy is the same as adult, except we need to monitor doses as per weight. Watch for toxicity of certain drug as ethambutol and streptomycin, and watch for change in weight, which occurs quite, I mean, you start ATT today and you decide to treat it for 1 year or 9 months. Then in this phase, child is going to gain weight, and we need to make a suitable amendment to the doses schedule. And these are the doses schedule as per RNTCP protocol, that these weight, they are put into 4 weight categories: 6 to 10 gram, 11 to 17, 18 to 25, and 26 to 30. And that's how these doses need to be increased as the patient moves from one weight range to the next weight range. General principle management TB spine remains the same for as far as the neural deficit is concerned, as far as the indication of surgery for neural deficit is concerned. But we need to be watchful for kyphosis in children. And which are these cases? There are 3 scenarios. Patients with active disease reports to you with no deformity. Patient with active disease reports with some kyphosis, and patient of healed disease and kyphosis. Patient with active disease and no kyphosis, treatment principle remains the same. Diagnosis, drug therapy are same as for adult. Continue to observe these children till the end of growth spurt, even after stoppage of drug for behavior of kyphosis, as we know some of them will progress. Patient with active disease and kyphosis, well, disease will heal, but kyphosis, is it going to remain the same or different? Then we need to know the natural history of disease in these children. Well, TB spine with kyphosis, some of them, they present with such a smaller deformity. Treat them appropriately as per indication of surgery by non-operative method if there is no other indication of surgery. But these patients which have reported with fairly advanced deformity, we need to take them for correction of deformity. To correct those who have severe kyphosis and presentation. And what is the severe kyphosis? Anyone above 50 degree, or those kyphosis which are likely to progress even after healing of tuberculosis, which I will be talking few slides later. Now, third category is patient with healed disease and kyphosis. For that, we need to understand the natural history of kyphosis in children. Well, behavior of kyphosis, as I said, some of them will continue to progress in spite with the growth, while others will remain static with the growth. So we need to find out which are progressive and which are going to remain static. And this is a landmark study where natural history of kyphosis in children has been studied, and we know that average increase of 15 degree on conservative treatment, 3 to 5% deformity more than 60 degree, deformity increases in active phase and after healing, and progress of deformity is more with severity of angle before treatment, label of lesion, and age of the patient. Summarily, 39% deformity increases, 44% deformity improves, and 17% no change. So we need to concentrate on those 39% cases which are likely to increase. And if we look in the graphical terms, this increment in this 39% would be of two kinds. They will continue to remain stationary for certain number of years, and then in the progressive spurt phase, they will increase. Or another one which will continue to increase in all childhood. While there would be some 44%, 17%, 44% which reduces in the deformity, and 17% where deformity remains the same. So we have to be watchful of this category 1. Now, in this study, 4 spine at risk signs have been suggested, and if 2 or more are present, then we can say that they are progressive kyphosis, and they are facet subluxation, retropulsion, translation, or if a line is drawn from distal healthy vertebrae and if touches the proximal half of the proximal healthy vertebrae, then this is likely to progress. Final kyphosis in a child depends on vertebral destruction and growth potential. Well, there is a lot of pictures, but I think if we take summarily, then TB spine in children is progressive because of 3 reasons. Anterior growth loss, growth potential is lost, or unabated posterior growth, which depends on segment of spine, number of vertebral body affection, or pseudoarthrosis, where anterior disease area does not form a bone block, it collapses on proximal spine, keeps on collapsing onto distal spine, and it gives rise to asymmetric loading onto the distal vertebrae, and hence this kyphosis is going to progress. So these are the 4 issues in TB spine in a child for a progressive kyphosis. And that is what do I mean by all that, that here this vertebrae is growing here in this direction, this vertebrae is growing here, there is no there is pseudo-arthritic in this segment, there is no loading in this part of the vertebrae, and this is going to increase exponentially, adding on to the kyphosis. And this is what is an example shown on an X-rays, and this kyphosis has increased from this here to this stage. This is another example, I would say, that we started therapy here, kyphosis was not big, but we were keeping this patient on a watch. We thought that probably this might not progress, but we were worrying about this part where it's not making the bone block. And 3 months later, one could see how the kyphosis has progressed. And the mother comes and tells the child is fine when he's sleeping. When he gets up and walks, his spine bends over proximal spine, and the deformity becomes very severe. And probably this we need to be looking to. So surgery to prevent progression of kyphosis, what are the options we have? Posterior spinal fusion alone, or correction of kyphosis in active disease. Well, as I said, if we have a progressive spine, and I have given this example, then by all criteria, this is a progressive spine. This deformity continued to increase despite a successful posterior spinal fusion in this patient. So if we have to start with a progressive kyphosis by our criteria, then posterior spinal fusion is not going to work. So kyphus correction, be more aggressive in active stage in correcting these kyphus who are likely to develop a healed kyphus more than 60 degree. And summarily, those are children where 3 or more vertebral disease in a dorsal or dorsal lumbar spine affection. And that's what correction has to be done. Well, the principle of deformity correction will be taken up by my another colleague. Why we are so worried about kyphosis progression? Because if this person continues to have this kyphotic deformity for years to come, then the patient is going to develop lot of problem: respiratory embarrassment, painful costopelvic impingement, severe lumbar canal stenosis if the deformity is a lumbar segment. So these all are going to produce a problem. And particularly if they develop a late onset paraplegia, then this prognosis is going to be further bad. Because we know in this late onset paraplegia, spinal cord becomes atrophic or myelomyelitic or syringomyelic. And even the vascular insult to the cord takes place. Hence, whenever surgery is done, it's very risky. It's always a bad prognosis because excision of this internal salient, this hard internal salient, is very difficult, and inadvertent handling of cord may leave permanent paraplegia. So hence they are poorer prognostic cases, risk of neural deterioration after surgery, and that is what is the example one could see here. One could see here that this internal salient